Hi, everybody. It's Bernie Polly, and I just want to begin with a territorial acknowledgement. And it is with great respect and humility that I acknowledge the Coast Salish, New Chalmouth, and Kwakiwak cultural families whose relationship with these lands on Vancouver Island remains unbroken and whose homelands are occupied by Island Health and the University of Victoria. I'm a third generation settler, and for the past 20 years, I've been living on the homelands of the Lekwungen speaking peoples of the Songhees and Wasanix First Nations. If you don't know whose land you're on and would like to find out, I invite you to visit www.native-land.ca, as many of you are joining us online from many different parts of the country. It is in making acknowledgements that we also need to make our commitments. And my commitment is to the ongoing work of deepening my understanding of the history of this land where I live, and in the work of building relationships and bringing voice to address long-standing systemic racism, institutional policies, and stereotypes that continue to cause harm to Indigenous people. With that, I'm going to just give a little bit of overview of how we're going to proceed today. I'm going to start with a bit of an intro to Tim. Tim is going to kick us off with kind of a central issue that I think we grapple with in our work. And then I'm going to give an overview of managed alcohol programs and some of our early research, as well as what's been happening with MAP during COVID. And then Tim is going to talk about some new analysis before we turn it over to you for questions and answers. I love the fact that I get to introduce Tim. I've known Tim for more than 15 years. I knew him when he was very first became the director of what was then the Center for Addictions Research of BC. And as you know, he facilitated the transition and continues as director of the Canadian Institute of Substance Use Research, a position that he's been in for more than 15 years. His background is in psychology, and he's internationally renowned for his work on minimum unit pricing. And so when I've gone to international conferences with him, I just glide around on his coattails, because he and I have been co-PIs on the managed alcohol research for actually almost 9 years. I think we knew that we were going to work together the first time that we were at a Christmas a holiday event in which someone had gifted, I think Tim, with a small set of wind up little people. And he and I were the first ones to each grab one and start racing them down the hall. So we're fiercely competitive, but we also are, I think, unrelenting in finding the answers to questions that we share in common. So I'm going to turn it over to Tim to start us off.
Thank you, Bernie, for that nice introduction. I'd just like to add to that metaphor. I've always thought it was a metaphor, those two racing people in that game. I felt it's been like Bernie and I these last 9 years, each working furiously and quite independently, and then realizing we had to apologize to the other for taking initiatives in our work without checking in first with the other. But we always forgive each other, and it's been a kind of a lovely creative process. I'm really proud and happy to have spent these years working with you on this. So I'd love to acknowledge the fact Bernie is my neighbour. We're talking to you from our living rooms or my home office 2 streets away in downtown Victoria. Thank you, everybody, for Zooming with us today on this webinar. I should say that Bernie is widely recognised. She's actually an honorary citizen of Victoria, recognised by the City of Victoria. She's an honorary fellow at the University of Stirling and recipient of lots of medals, including the Queen's Diamond Jubilee Medal for the amazing work that she does. She's a professor of nursing at the University of Victoria, and she's a scientist with us at the Canadian Institute for Health Research, and she has many other roles. So I'm now going to try and share my screen and start us off with the presentation. And I just hope this goes smoothly. So let's see. I hope to heck you can all see this. So here is the title, and I'm going to move my image off my screen, but without success. I'm going to minimize it. Thank you. So this is the subject of our talk. We're looking at managed alcohol programs, once a uniquely Canadian response to people with very severe substance use disorders, alcohol use disorders, accompanied by problems associated with unstable housing and other comorbidities. I want to acknowledge this is the work that's been conducted by a large team of people, and I've highlighted my colleague Jinqui Chow, who quietly behind the scenes has helped us with all the huge amounts of data we've gathered to try and analyze it and make sense of it. And I'll be presenting the results of some of his analyses today. Now, I'm trying to forward my slides and I've succeeded. So alcohol is, we have such a long historic relationship with alcohol, and I just love this quote from the poet, the Greek poet Eubulus, from the 4th century BC, which I think said it very nicely about the complexities of alcohol use, the dose-response effects, and maybe this is one of the first guidelines. So I'm sure people have been giving advice to others about their drinking for millennia, even before this. So he talks about the different effects, 3 bowls do I mix for the temperate, 1 to health, which they empty first, the 2nd to love and pleasure, the 3rd to sleep. And when this bowl is drunk up, wise guests go home, and you can see how this goes. The 4th bowl is ours no longer, the 5th is uproar, and we go all the way through biliousness, and finally the 10th drink to madness and hurling the furniture. These words, echo down the centuries. We're going to be talking about studies of people who, on average, are drinking roughly twice that last level. And we're going to look at some of the complexities about how we reduce harms for those people. So this may have been one of the first guidelines. Last week, I'm very proud that my colleague Adam Shirk had this paper published in the Journal of Studies on Alcohol. Maybe it's one of the most recent advisories. It was covered by the Globe and Mail in an editorial with a beautiful, elegant analysis of all the data that's been collected worldwide, pretty much. He came to the conclusion that actually low-risk guidelines have been set too high, and really it's about 1 drink per day for a man or a woman, that your risks of premature mortality are about break even. You're as likely to get benefits, especially if you're female, as you are to experience harms, and above that, things get worse. Quite consistent with what Eubulus and Adam seem to be in agreement here about 1 drink a day being for health. The costs, sorry to do a big downer on this. So just before we talk about alcohol and harm reduction, we have to be aware of the bigger picture. The Canadian Substance Use Costs and Harms Project is about to come up with very precise estimates for the costs and harms of 8 categories of drugs, including alcohol. Once more, they will show, and this has been consistent, it's not new information, the economic costs of alcohol are greater than those individually for tobacco or collectively for all the other substances combined, including opioids or cannabis. And contributing to this are more than 18,000 preventable deaths, more than 100,000 hospital admissions, more than 700,000 ER presentations. Should note that these levels of harm are kind of a lot greater, well, certainly for the hospital admissions, than even COVID. I mean, we're talking about a massive, quiet epidemic going on in the background of our lives, which we pay scant attention to. And in fact, in Canada, governments are busily deregulating alcohol policies, which is leading to increased harms. And in fact, during the COVID crisis, a lot of relaxations have been relaxed, which has led to increased consumption and will add to these harms. So the harms, we need to break them down. They are not just one homogeneous lump. There are so many ways in which alcohol can give us pleasure, but also pain. Acute harms, the injuries, the poisonings, acute illnesses, the chronic harms from drinking over many years, cancers, liver disease, the social problems, the havoc that some patterns of drinking can wreak in our lives, and in some cases with housing, finances, relationships, and so forth. Here is, I think, eloquently illustrated one kind of acute harm, freezing deaths, which of course occur sadly in Canada during the winter months. When I lived in Australia, the opposite used to occur, that people would die. Alcohol would contribute to dying from dehydration or from during excessive heat. The first managed alcohol program was a response to an inquiry into the freezing deaths of 3 men in Toronto. And so this is the other reality, that sometimes the acute harms are so intense and severe that all the other advice and advisories, the guidelines, go out the window. We have to save lives, reduce harm, because it's compassionate and it's pragmatic. So we have competing views, perhaps, on how we respond to alcohol's harm. A population health perspective notes considerable harms for the whole population, and effective interventions will mostly involve increasing price, especially targeting cheap drinks, reducing physical availability. That's just for starters. However, an alcohol harm reduction approach we're talking today suggests that vulnerable people with severe alcohol use disorders should be provided with alcohol regularly throughout the day and at minimal cost in order to reduce acute harms. Can we reconcile these competing views? So this is my last slide before I hand back, this time to Bernie. It's been estimated people with a severe alcohol use disorders live 25 years less than most of the rest of us, on average, of course. So managed alcohol programs, nonetheless, are based on the compassionate, pragmatic principle that these harms are like freezing to death, street violence, withdrawal seizures are so pressing that we actually need to provide a managed supply of alcohol that in order to increase both the quality and length of life. Our CMAPS research program tests this hypothesis, and we'll tell you more about that now. Thank you. I've got to unshare. See if I can do that. Over to you, Bernie.
Perfect. Well done, Tim. Thank you for setting it up. And what I'm going to do is pick up and talk a little bit about some of the CMAPS research around impacts and outcomes of that program. And like Tim said, we have a very large team that includes both our research coordinators and assistants, as well as many partners across the country. I often have about 3 slides at the end of any presentation naming who our partners are. We've been very fortunate to have significant funding actually for about a decade for this research from, as you can see here, Michael Smith, CIHR, and others. Tim already mentioned the harms of alcohol use in terms of acute, chronic, and social. And those harms, as Tim described them, really drove to the development of the Canadian MAPS. And as Tim identified, one of the first MAPS was in Toronto. But one of the very well-known MAPS that came after in the early 2000s was the Ottawa map. And there's, if you really want to get sort of a picture of a map and you're wondering kind of what does this look like, The Poor by the Fifth Estate is a documentary that was done on the Ottawa map. And there's an article done by The Guardian a couple of years ago in terms of also focuses on the Ottawa map. Unfortunately, we get headlines like the shelter that gives wine to alcoholics. So, MAP is sometimes seen as a more controversial approach to addressing these acute harms that often combine the acute harms of very high risk drinking combined with other harms like homelessness, for example. And yet, as Tim mentioned, communities recognize the need for a very compassionate response. And so they've turned to harm reduction. So MAPS are a form of a harm reduction program. So focusing on preventing the harms associated with high risk drinking and severe alcohol use disorder. And they fit into the continuum of other services and supports for individuals. Something that we did not, and we should have anticipated, was that with the advent of COVID, the risk of harm for people with alcohol use disorders and homelessness was accelerated. And I'll just sort of briefly touch on some of the changes that occurred. For people in very, inadequate living conditions with, inadequate incomes related to panhandling and recycling started to disappear. Liquor stores in some cases limited hours or did not take cash. There were shifts in the availability of intake into detox and treatment services, and the daily cycle of survival drinking, in which people are trying to source their alcohol, became extremely even more difficult. And I know in our context, one of the consequences was increased presentations of withdrawal in emergency departments. Services were limited in terms of shelters and other resources, and even those that were available, drinking is often not allowed. So we had a situation, as I mentioned, of increased risk of withdrawal, increased potential for turning to use of non-beverage alcohol, substitution of other illicit drugs when alcohol wasn't available, and the impacts of increasing social isolation. So some responses that occurred was a real recognition of an awareness of the gap that there is in alcohol harm reduction, and that we do not have very robust systems that incorporate alcohol harm reduction interventions. So I'm just going to highlight a few things on behalf of our team. One thing that we saw we could do immediately was to focus on the development of safer drinking education, so that people could be able to themselves or their friends or family quickly identify who was at high risk for withdrawal, and some tips for safer drinking, which you can find on our website. But also the recognition that MAPS can increase the ability of people to physically distance, stay in place, and isolate. We've just developed, and it's on our website, an FAQ related to the scale up of MAPS. Provincially in British Columbia, the risk mitigation guidelines, which many of you will be familiar with, around safer supply of opioids and benzos and other types of to replace illicit substances, also includes a reference to managed alcohol in cases where medication, where usual treatment for AUD is not available, or it is not an option for that individual. And in addition to that, we're just on the cusp of releasing provincial MAP operational guidance to complement the risk mitigation guidelines. So that resulted in, probably to our knowledge, across the country, maybe 10, I think 10 is probably an underestimate of new, what we would call COVID MAPs. And the COVID MAPs were sort of initiated as a response to assist with putting into place COVID responses. Some of those MAPs are ongoing, and some of them are intermittent. And that's in addition to approximately 23 MAPs that we know of in 13 Canadian cities. Our research has focused specifically on work with about 10 MAPs. And the purpose of our research, has the Canadian Managed Alcohol Program study, has been to rigorously evaluate MAPs in Canada and generate insights into the implementation and outcomes. And you can see here our specific question. Because MAP is an alcohol harm reduction intervention, we wanted to know, does it reduce harm? And that's been a primary issue in terms of reducing alcohol-related harms. We do look at impacts on consumption, not so much to reduce consumption, but to ensure we're not increasing consumption. Looking at housing tenure, health, quality of life, and reducing economic costs. And how does that happen through programs? That's the implementation question. We look at outcomes through quantitative surveys. Our database of participants, our cohort is about 364 participants, about half of whom are in a MAP and half of whom would meet the eligibility for a MAP but are not. So we refer to those as controls. We have a massive secondary administrative data set, which is hospital data, corrections, police and corrections data as well, to look at those kinds of changes. And then we look at implementation through our qualitative interviews and through policy and protocol analysis as well. So what I'm going to do is just briefly, in a couple minutes, summarize. I'm actually going to do it, I'm going to put about 9 years of research into 2 slides. So what have we learned about MAP outcomes? Well, we've learned that those individuals who are in a MAP are more likely to retain their housing and also experience increased safety. Tim touched on, you know, the harms to people living outside, of freezing, but also harms like assault. And violence, and feeling much more at home and having a place in the world. Reduced hospital admissions and time in police custody, as well as how those translate into economic savings. And all of these papers and reports are on www.cmaps.ca. Although people are drinking daily, they tend to be drinking less non-beverage and drinking lower quantities of alcohol overall compared to people in the who are acting as the controls. And as Tim often says, it smooths out the pattern of the drinking, so less kind of binge drinking. So drinking more days, but often drinking less. That came out in some of our baseline analysis. And then fewer reported, these are self-reported physical harms like withdrawal, seizures, assault, and fewer social harms like legal, financial, and relationship harms. And then improved quality of life and opportunities within the MAP to reconnect to family, community, and in the case of some programs, with culture. In terms of the implementation, we've mapped out the key dimensions of MAP, and I just want to mention there that managed alcohol, while it does provide regulated doses of alcohol throughout the day, that is not the whole of a MAP. It also includes food, social and cultural supports, access to primary care, and as well as stable accommodation, because most individuals prior to coming into MAP have not had stable living arrangements. Individuals on MAP are also less likely to rebudget for essentials, drink non-beverage, steal or commit crimes, and more likely to go to treatment. And also, you know, less likely to use illicit drugs as a substitute. We have found through our research, and Tim is going to touch on this more, is that it's really important in the implementation to pay attention to program eligibility, the policies, and how doses are tailored in order to reduce both acute and chronic harms. And he's going to talk a little bit more about some of the newer findings that really kind of point to that. What I'm going to do for the last couple minutes that I have is talk about how MAPs disrupt the constant cycle of displacement and survival. We did something called a situational analysis, where we used our qualitative data from over 100 qualitative interviews, some from staff, some from people who are in the program, to visually explore the elements in a situation and map the relationships between them, so that we were not just looking what was happening for individuals or the program, but we were looking at how is the program situated within existing housing, health, and social systems. And so here you can see what is considered to be the pre-MAP situation, where we have healthcare arenas, criminal justice, we have the shelter housing arena, we have the street community arena. And so within that, people are cycling through those kinds of different arenas. Many of them do not tolerate alcohol, or individuals are not able to stay in those settings. And there's the pre-MAP arena of displacement and survival. When we introduce a map into those same set of arenas, and I'm just going to pop up here, you can see all of them. What we're doing is we're introducing a world that is focused on a harm reduction intervention that enhances safety and security and connection to self. It's a fairly complex analysis that I've laid out in a fairly, I hope, understandable way, but this is the shift that happens from pre to post MAP. And that's a very fragile process, which there are many, skilled individuals, who work to support people, because we're going from a situation in which people have faced incredible amounts of stigma, being told they don't belong anywhere, to a place where they're invited to be at home. And that is a very important part of implementing a MAP and putting it into a context in which there are a few alcohol harm reduction strategies. We'll come back to some of the current and future research at the end, but I'm going to turn it back to Tim to share his screen and to finish up. Not to finish up, he's going to do the meat of the sandwich here.
Thank you, Bernie. I'm just trying to get my screen sorted so I can read it. Hopefully you can all see it. So I'm going to just run through some new analyses, which are perhaps the most rigorous and exacting tests of some of the aspects of effectiveness of MAPS. I'm not going to be looking at the quality of life here. I'm going to be looking, sorry, I've got to advance this screen. Yes, I'm going to be presenting two new longitudinal analyses. So they're going to be looking at impacts on mortality and self-reported harms, not so much to do with the quality of life, but perhaps the quantity of years lived and so forth, with some survival analysis. So the first analysis looks at people who we followed up over a 12-month period. So early on, after 6 months and 12 months, we required for this analysis that people were on the MAP to begin with no more than 60 days. We had only 59 of those across the 6 sites. And we compared them with matched controls as best we could from the local neighborhoods who could have fitted the eligibility criteria for the local managed alcohol programs in that city they were living in. We were then able to access mortality and healthcare data, ER admissions, hospital admissions, for 205 managed alcohol program clients from the Ontario sites, and 131 controls over an 11-year period. So kind of a powerful analysis and opportunity. So starting with study 1, just to say that things sort of whittled down. We started with 216 MAP participants screened to be eligible, of whom 71 eligible people participated, and then we weren't able to follow up. We were able to follow up about 85% of those selected at 6 months, but the study data collection period ended too soon to be able to follow up some at 12 months. So we ended up with smaller numbers followed up at 12 months. Larger numbers for the controls, but that's just to show how some of this process goes. Because of attrition, because of people dropping out of our study, we had to do analyses which sort of controlled for those differences in dropout. We use standard procedures for that. Now, at the outset, both groups were fairly similar. 80% male, on average 46 years, many indigenous people, severely alcohol dependent, and the distribution of our participants was even across the 5 cities. There were some small differences, though, at the beginning of the study. The managed alcohol participants reported from the beginning more non-beverage alcohol use, perhaps reflecting the strong emphasis on that aspect in the eligibility criteria for the sites. And controls reported significantly more harms on one of our harm scales than did the managed alcohol participants, and that could be an indication of some early benefits of being on the MAP, or it could be some sampling bias. So we just have to bear in mind this limitation as we go forward, looking at the results. At 6 and 12 months, both groups, the MAP and control participants, reported fewer drinks per day and fewer drinking days per month. This is over the 6 and 12 month follow-up times. The managed alcohol participants, people reported, were the only ones to report significant reductions in non-beverage alcohol use. And we weren't able to assess this in the controls, but we had evidence of reduced liver function scores, so improved liver functioning at 6 months, though that was transient. The controls actually had significantly fewer drinking days per month throughout the whole period, which isn't surprising. MAPS are supposed to provide people with alcohol every day. They also had fewer harms than MAPS and significantly reduced harms at follow-up. So that there was significant, the MAP people on our scale, remember they had fewer harms at the outset. So whether that's a fair comparison, but we just have to report the findings as they are. However, we did another analysis where we contrasted outcomes for 2 kinds of MAP programs, those with stricter policies on outside drinking and those with quite a lot of outside drinking going on. And there were massive contrasts in terms of follow-up of many fewer drinks, about 8 drinks per day versus 18 drinks for those with the less strict policies per day, compared with 13 for the controls, and also significantly fewer harms compared with either the less strict MAPS or the control participants. And we made these comparisons adjusting for age, sex, ethnicity, and site-specific factors as well. So that's a bit more encouraging, but we have to be mindful there may be some unintended negative effects that we have to be aware of, because control participants do reduce their mean daily alcohol use to the same extent and were the only ones to have significantly reduced harms. They consistently drank on fewer days per month than MAP participants. And for the longer term MAP participants compared with the early ones, they did have higher, as time went by, their liver functioning for some did deteriorate. So we have to be aware of these longer term problems, and for a complete harm reduction approach, be very thoughtful about how to respond to those. I'm going to keep moving a bit more quickly, but just to note that we haven't looked in these analyses at quality of life. As Bernie mentioned, MAP participants keep their housing, and there's many other benefits they're reporting from being on the programs. There were limitations with our study, and it's clear that we need to look more at the types of policies, and managed alcohol programs are not homogenous. We need to find out more about what makes a really effective program. Okay, I'm now going to just finish with looking up a couple of slides on the mortality and healthcare analyses, very new. Jinqui Chow is a biostatistician at CSER, done some fantastic work, and I hope I do justice to it. This is a much stronger analysis, 11 complete years. We had the exact dates of deaths, ER and hospital presentations, more participants than the other longitudinal analysis, and nobody is lost to follow-up. Jinqui used multi-level survival analysis, comparing the probability of MAP clients dying, attending an ER, or being admitted to hospital, controlling for the number of days they're on the MAP or off the MAP, and comparing them with neighborhood controls who I've described. So Here's the first set of results. I just wanted you to focus on the 0.45 number at the bottom of your screen, near the bottom, in the middle of the screen. This is the comparisons of the hazard ratio, the probability of dying as a function of the number of days, follow-up days. So there were 41 deaths observed across the MAP participants and 29 for the controls. And taking account of all the times they were on MAP or off MAP, there was no significant difference, but with the comparison with being on the MAP and the controls, though the much lower hazard ratio of 0.54, but that wasn't significant. However, comparing the risk of death for people on a MAP compared with the times when they're off the MAP, it was like a 55%, lower. Their risk of premature death was 45% of when they were off the MAP. So some indication of protection there. If we look now at emergency room presentations, we find evidence that it's roughly 73 or 74% risk of attending the ER if you are on the MAP compared with the times prior to going in the MAP, almost exactly the same risk, or if they left the MAP after being on it for a while. There were no significant differences between the MAP participants and controls on this, though there was evidence of significantly fewer ER presentations for non-alcohol-related issues for people on the MAP, but there were significantly more alcohol-related ones, ER presentations, compared with controls, and they evened out. So evidence for some protection against ER presentations. We didn't find significant effects for hospitalization rates, so I won't show those. And here are preliminary conclusions. Attendance at MAP has these possible protective effects, was associated with a 45% reduction in mortality risk and 27% roughly fewer ER presentations compared with times not on the MAP. No significant differences though compared with the neighborhood controls, not engaged in the programs, haven't looked at the quality of life. There was an increase in alcohol-related ER visits for MAP attendees versus controls for alcohol-related ER visits, but that was offset by the non-alcohol-related ones. We need more analyses about the specific policies and application of eligibility criteria. So provisionally, it seems that for the right people on the right program, we might be able to sort of reconcile these apparently opposing universal and targeted strategies, like the pricing and availability policies versus these harm reduction programs. And here are my ideas about, and we can have some discussion about this, how do we reconcile these universal and targeted strategies? What principles might we apply? I suggest we always need to be alert to unintended negative consequences, both of population-wide policies like pricing, as well as targeted policies for vulnerable groups. Both may have unintended negative consequences, which we have to be mindful of and try to address. For MAPS need to carefully develop and apply strict eligibility criteria. So these programs are not for everybody. The principle of do no harm is very apparent. We should not be administering more alcohol than MAP participants would normally have drunk in a day, and maybe less. Strive always for safer alcohol products, drinking in safer places in a safer pattern through careful implementation of MAPS. And also, increasingly, we should support participants wishing to reduce or completely stop their use. So, I'll hand over to Bernie. Well, Bernie's going to speak to this, and I'll just leave this slide up, and then I will stop sharing so you can see Bernie.
Sure. Thanks, Tim. So the Canadian, this is www.cmaps.ca, and everything that we've reviewed on there, you can certainly share and use. If you want to join the community of practice, you have access then to more in-depth information. Tim, I'm just going to follow up a little bit on Tim and identify some of the current and future research that we've got underway, because although we've been doing research for 9 years, we recognize that there are still a lot of questions. We've answered some about MAPS in terms of the ability to reduce harm, and the new survival analysis is particularly important around, we knew MAPS were effective in reducing acute harms, but the survival analysis provides support for it reducing chronic harms. We're also been looking at the feasibility of cannabis substitution for alcohol. We are working led by U of C, Alpha House, and Aboriginal Coalition to End Homelessness, to look at developing Indigenous culturally supportive MAPS. We are specifically looking at the COVID risk mitigation guidelines that include MAP, and looking specifically at this question of harms and consumption in a context where there is a different set of policies. And I think one of the huge questions we have is, what kind of policies are going to produce the best outcome? And it's much like many other policies, you have to find the sweet spot. We've done some initial analysis that we haven't presented here that sort of suggests you don't want overly restrictive policies, but you need some kind of policies that support participants. And then we're working with University of Stirling, also looking at MAP effectiveness during COVID. So those are some things going forward. And I'm just going to stop sharing my screen. And I think to start us off, there is a question that I think is really important to answer. Could presenters comment on the findings re-ER presentation? This seems like a surprising / disappointing finding. I'll maybe just comment quickly. Tim, we didn't mention specifically the fact that when we looked at the Thunder Bay program by itself, the ER presentations and the police and the cost savings dropped dramatically, and that's a report you can look at. And Tim, do you just want to comment on the fact that this looked across multiple programs, or what's your take, because you're looking at many programs versus kind of one program?
I would prefer, thanks Bernie, and thank you for the question from Dr. Bartzman, Anita Bartzman. Yes, I mean, you never know what your results with these kind of studies are going to throw up. I would prefer to emphasize, I would also emphasize the positive finding, which was, the significant difference when you look at the risk of an ER presentation of any kind on days when people were attending a MAP compared with when they were not. So using people as their own controls, MAP participants as their own controls, there was very substantially, and a highly significant protection against attending emergency rooms. And that applied, we controlled for variation across the sites, and that was the case. With the controls, there was just there were no overall significant differences in the rates of ER presentation. There were questions about how comparable the controls are with the managed alcohol participants. That's one question. I would note that actually, although it wasn't significant, the hazard ratio was still much, much lower for MAPS than it was for the controls, even though that wasn't a significant effect. So, yeah, it's what it is. And I think we also need to look at the quality of life analysis. Bernie, I don't know whether you want to talk. We haven't yet reported findings, the longitudinal analysis of quality of life outcomes.
Yeah, and we also, Tim, have yet to look, I think, at the housing piece as well, like the longitudinal aspect. We know from some of our pilot studies and early work that people are retaining their housing. And we need to look more specifically over the longitudinal in terms of their quality of life. The other thing we also have to remember with healthcare is sometimes people, I didn't mention this in my analysis that I showed using situational analysis. But as people are cycling and they're going through those various sectors and systems, they are actually touching different systems, but they are not getting the care that we need. So we always have to be very careful when we interpret access. Is it because someone wasn't receiving care before and they're receiving care that they require now? We still would question why the emergency department, because MAPS often incorporate primary care, which again, might explain why in the Thunder Bay program, who had a good connection with primary care, the ER presentations went down quite significantly. Just looking.
I'll
Yeah,
go
Tim.
to the next one, Bernie.
Fabulous.
Question here about the little analysis comparing the two kinds of maps. We had data, we published a separate paper looking at outside drinking and finding that some of the programs had substantial amounts of outside drinking, which they would tell the researchers. They wouldn't actually tell the staff about necessarily. But Thunder Bay was an interesting case in point, because the question here from Griffin Russell is whether it's really implying, well, if you have strict policies, maybe you have poorer retention. And so that could be a trade-off. You have strict policies, good outcomes, but you don't, retain as many people. Actually, Thunder Bay was an example of one of the sites where they had strict policies, and they had incredibly high retention. People rarely left. So in that site, I can guarantee it had no detrimental effects on retention, and there were substantial outcomes. So we're kind of aware that sites run their programs quite differently, and we have to study these more and find out what are the magic ingredients which combine retention and good outcomes. It's quite an art, I think. So we have to interpret all these disparate findings accordingly.
I apologize. I'm going to take, how about Tim? I'll take a next question here. It's one I feel like I've been thinking about a lot, and that is, how is appropriate dosage determined for individuals on a MAP? That is such a timely, important question, because I would say pre-COVID, dosing was often determined in kind of a one size fits all with some tailoring. So it was typically delivered, at one standard drink an hour up to say 11 or 12 standard drinks a day. In working on the operational guidance for MAP and working from the premise that this is a harm reduction program, and we've always known that tailoring is really important for the reasons that Tim's identified. We don't want to increase someone's consumption, and consumption might be quite variable. Someone may be drinking 2 liters of wine a day versus 3, but in the operational guidance that we've been developing in the clinical guidelines, we've focused on assessing what the person is drinking now and determining with them what is a safe level in which they can maintain, not withdraw, but also not increase. And so the standard dosing is being much more individualized. And I totally appreciate, I've had a lot of calls from physicians who often say, well, just tell me, how many drinks a day, which is an approach that is very common in medicine, but this is a harm reduction program in which you're assessing, what's the level of drinking and how can we reduce the level in harm for someone. And so we've got some pretty detailed, I think, advice around assessments and developing individual managed alcohol programs to prevent harm. So I'll turn it over to Tim. Do you have a question you want to do next?
I would just comment on that, though. I mean, I think it's very early days to know how things are going to work with COVID. So moving from, these hourly doses that have been set up in these residential managed alcohol programs to dropping off alcohol once or twice a day to people in various circumstances, we don't know how well that works, or how, that what we're discussing before about the different policies, that obviously there won't be, it'd be harder to limit outside drinking, but maybe there's less outside drinking during COVID. That's the whole point of providing it to the doorstep, so hard to compare. But the dosage, we have observed with some more sort of naive new programs, them trying to shoehorn everybody into the same dosage structure. I remember one situation where a person was only drinking 6 drinks on a Saturday night and they were being recommended for a managed alcohol program. That was stopped. I mean, that was just early confusion about what's needed, and hence, one of our guidelines not to exceed the amount of drinking people are normally drinking. There's also the advice to bear in mind from any liver society or specialist that a day or two off will be good. And Oscar Wilde used to have liver holidays. He would stop drinking for a month or two, probably preserved his life, and we have more Oscar Wilde writings as a result. So we have to bear all these things in mind. People are very different. They have different tolerances, different body weights. And the general principle of not having a higher volume and moderating the pattern so it's smoothly spread out. So dose and pattern is important, but also being mindful of substitutes to take the prey, because this is a toxic carcinogenic substance that does more harm to you than probably almost any other recreational drug that we put in our bodies. And if we substitute cannabis for it, or if there's drugs to help with withdrawal and they're not mixed too much, we can reduce the impact of alcohol on the body. And I think it's important that individuals understand these things and we tailor, negotiate the kind of dosage regime and monitor it with them and help them make good choices about how they use alcohol going forward.
There's a couple of questions on eligibility, so maybe I can tackle those, and then Tim, maybe you can tackle one of the other ones, because I think we have about 5 minutes left. Regarding eligibility, the way that eligibility is usually defined by each program is that this is an individual who has a history of very heavy drinking in the realm of what would qualify for a severe alcohol use disorder, usually combined with homelessness. And it's also an individual who is who's had many attempts and multiple sort of experiences in an abstinence-based program, who is saying, I actually don't want to do that anymore. I don't want to do that right now. That's not my goal. My goal is, I don't have goals around quitting drinking. Within a MAP, you can definitely have goals around reducing drinking or maintaining drinking. And so those are the individuals that generally would be eligible for a MAP. So it's offered after other treatments are offered, including medications. So sometimes individuals may have received acamprosate or naltrexone, but we need to remember that those medications are often more appropriate for people who have goals of cutting down or quitting. So definitely that's been on offer. So Tim, I'll turn it over to you, because I think we're at our last question.
Yes, there's so many, thanks for all the questions. I hope we can try and answer them at some other means. I'm looking at one from John McCade about what policies and procedures were in place in those facilities with stricter controls. And I keep thinking of Thunder Bay as this lovely example, the program there. So what was negotiated with the clients and they brought into and understood, there wasn't so much top down, it was a real community support. that there were room searches. So if people were hiding alcohol away, everybody knew that might undermine their progress collectively. They would, and that would be confiscated. If people showed up at the time when the next dose was due and they were visibly intoxicated, they'd have to wait another, I think initially 90 minutes, and that was reduced to 60 minutes for their next dose. So that was all being monitored. And I think that this whole top-down versus bottom-up issue is important to grapple with. And I know in the Ottawa, one of the first maps in Ottawa, it was actually the residents that demanded there were stricter policies because they wanted to be able to sustain, their more balanced life with a more managed use of alcohol, and it wasn't disrupted by people who weren't supportive of that. So that's probably it at 12:59. A really huge thanks to everybody, and sorry we couldn't get through all the questions, and perhaps we can try and do that. If we can think of some way of getting some answers to all of those questions offline.
And I just want to say the questions that you've got up there are just exactly the ones that I think are, we've been working with, and some we have research answers to. So like Tim, I hope we can answer them for you soon. And I just want to thank everyone for joining in. The webinar was recorded, and I think, Amanda, if you want to say anything before we leave about how that's available.
Yeah, it's recorded. It's actually being broadcast live on Facebook right now too, so you could probably watch it right away on Facebook again, instantly, but I'm gonna also edit this recording and put it on our YouTube page as well.
Great. Thanks, everybody.
Thank you. Goodbye.
Bye.